Hello, and thank you for having waken up so that to participate in this very best roundtable of CHAM 2024. Thank you, Guy. I don't know whether he's here, but thank you very much for having offered me to moderate this particular roundtable. After last year, we have had bioterrorism and the previous year and many different things. And when I saw that there was a person from the automobile industry, I thought that he was going to give me the moderation of that particular roundtable, but fortunately, he actually gave me another roundtable, a better one. But I would like to say that I'm never happy with what I have, and well, I am a practicing cardiologist, so I will not be giving my opinion so that I won't be chased away from this Congress. But finally, I will be able to talk during this roundtable about the wages of the healthcare professionals. Well, I think that this is basically, this means getting deeper into the world that is just as complex as the composition of the government. Well, no one is happy in this world. The doctors that are saving lives, the professionals in general, we understand that, and you understand that you have to be paid 4 times more. The patients want to pay less, and this is the case not just in France. And in the middle, we have the Social Security that would like to pay less, despite the treatments that are getting more and more expensive. And they're not just the payers who are interested in that, and we also have the population that is getting older and older. So this is quite complicated. Of course, we have already talked about the lack of healthcare professionals and private doctors as well. And probably this is also something that is related to the wages of the healthcare professionals, because during the last 10 to 15 years, it has been stigmatized a lot, and administrative constraints have increased for all the doctors. And of course, they don't really want to open their offices. While 30 years ago, it was a different situation, we understand it. So very fortunately, we still have some people who are willing to go and do it, and also some people who are here to generate different ideas. And these people are here on stage with all of us today. Just before we start, I would like to ask this same question to absolutely everyone, and I would like to have an answer either yes or no. Jean de KERVASDOUÉ, and I will have to manage all of this because he will be talking as long as you give him the time for. So I would like to know, are the wages of the healthcare professionals corresponding to their fair value, yes or no? It depends. The answer of Jean KERVASDOUÉ. Patrick, no. No. Marguerite? Surprise, no. Great. That's a great start for all of us. So, Jean, you are working in the economics of health. Of course, the health does not have a price, but it has a cost. Well, I think that in order to talk about this question this morning, it is very important to remember 2 contexts, the French context and the worldwide context, and I will do it very quickly. The worldwide question context means that all the world healthcare systems must be part of it, and this is basically the knowledge and the innovation that are influencing them. We know that we have 500,000 articles in the journals, medical journals, that are being published every single year, and we have this hypothesis that all the doctors have read them, but this has not a lot of consequences, and this is ridiculous. And we also understand that it actually divides the work, and it actually doubles the work, and this division of work within the healthcare world, because we have 55 medical jobs that are recognized, but we have much more of those. And we also have the order of the paramedicals that are here. So we have approximately, we have much more. And the systems of the payment for the acts are only paying for one of the columns, for only one of them, but there are many of them. So this double division of work, we have already tackled it yesterday. So this is the coordination of the refunds and whatever is compensated. Okay, wait here. So for the French context, I would like to say a couple of words as well before diving into the depth of the topic. So just to go back to the remark that you made, means that in 1970, we had 51.7 million inhabitants in France, and we had 72,000 doctors. Right now we have 230K doctors. We had 500,000 nurses, and we have much more today. So we see the question is not related to the quantity. The question is to see how we will organize this system and organize ourselves within this system. And the organization is very bad. So we have basically 3 ways to pay the doctors, and we're using only 2 of them, and we're using them very badly. The very first way for paying the doctors is, of course, the salary, the wage. But the way that we're using it, we're paying everyone in the same way. And I'm here talking about the general practitioners, but also the public function. And basically, this is what we have talked about yesterday. We are paying the surgeon just as we're paying the biologist, and this is unfair. The second system is the payment for a medical intervention, for an act. Well, it actually supposes that we have to, first of all, define the action or the intervention. But we are talking about the nomenclature with all the innovations that are coming in and getting out. But the management of all this nomenclature by the collectivity and the state is extremely bad. And it actually creates a lot of debates and a lot of inequalities, and the state, well, with this algorithm that we have it, as we have it today, we still have a lot of work here. And the third system that we are using in France is the forfeitary, I would say, payment. And it actually represents quite a lot, like a fixed fee system. And it actually has a lot of potential, I believe, because I believe that it's much better to pay, let's say, for a treatment of a person for one full year, but let's see what happens at the level of the social security. But it also it actually divides the price of the prescriptions per 2. So let's say for the general practitioner is 1 million euros of prescriptions. So if we can lower that, it will be very interesting. So the question here is to know how we coordinate the treatment and the care, and the ideas that we have here in France. We have basically wasted them all. We are wasting this idea of the family doctor, but also of the treatment, because well, because of the current situation, we can see it. And what can we do about it? Well, we should offer. I would like to stop you here because we are just looking at the situation without any proposals yet. So, what is the situation in Europe? Well, it's different. Well, how do we practice the medicine in Europe? It actually depends on the country, but there is this difference between the north and the south. Well, for all of the countries that are the northern countries, this will be the fixed fee, annual fixed fee, and the capitation with medical centers. And these medical centers have an economical system, whereas in France, the medical centers don't have an economical system, so they are financed in many different ways. So through acts, but also by the local communities. So we actually lack this stable and autonomous economic model that will allow us to find the units for coordination and for production that will be compatible with the evolution of the worldwide technique. Because as I haven't said it, but it's obvious for everyone, this evolution of the knowledge, but the specialization also means the death of the small hospitals. So the question is to know how and by what we're going to replace them. We are going to replace them by the medical centers, where we'll have 7, 8, 9, or 10 general practitioners, approximately 20 nurses, physiotherapists, pharmacists, etc. And this will be per territory, because the capitation is not just the capitation for doctors, but this will be for a doctor and their team, meaning that the capitation will mean the doctor plus the nurses that are working with them, and we will be paid per team and not just per person. Marguerite, what about health insurance? Do they look a little bit at what is happening around and probably getting inspired by all of this? Yes, indeed. And we actually have this tendency to say, well, everyone, that this is a little bit like the Olympic Games effect, that we're bad, until we understand that we're not that bad. And this is the same thing with the healthcare system, because we have this tendency to say that we're living in a third world country in terms of the social protection, that we're heading nowhere, everything is going wrong. But whenever we're comparing ourselves, it's comforting. When we're looking at the NHS today, it's comforting for us. When we're looking at Germany, we had this wonderful study by IRDES that has been published. In Germany, they have hospital capacities that are much more important than what we have. And during COVID, we were looking
looking at it and we were saying, wow, this is wonderful. They have many beds in the hospital in Germany. Why do they have it? Because they haven't made the shift to the ambulatory care. And today, for one bed, we have 2 times less caregivers in Germany than in France, meaning that they have many beds, but they don't have enough caregivers. So the care is less good for patients, meaning that the hospital capacities in Germany are way too big with beds that are full. Well, in fact, you actually have to look at all the different systems, because we have had some systems with capitalization that led to the financialization systems, etc. Capitation? Yes, capitation, indeed. And then, well, we actually had the financial community that took over their capital. So what I would like to highlight here, and I will stop here because I have other much more interesting ideas to highlight. So my highlight is that we don't have a perfect healthcare system. This is not true. And the fact that we're saying that we have to examine everything in detail and then to overturn everything so that to build something anew, this is the world of the ideas. So it means that our healthcare system is what it is. So we have to start from the strength that we have today, because it is not true that we're crushing things constantly to be able to rebuild. I believe that we already done too much, especially in terms of the financement of the hospital, because every single year we have a new reform for the hospital, and this is very complicated for the caregivers. In France, we are lucky to have the liberal system that works. We have this advantage to have a public sector and private sector that are satisfying the needs that are different but complementary. So we have all of this strength. We have to capitalize, to manage to capitalize on all of it. And honestly, our liberal system here in France has a lot of things that are the object of envy in Europe, and this is part of our strength, in the same way as we have this possibility for the young doctors who don't want to apply the FEPR Medical Act. We gave them the possibility to work for the healthcare centers. And we can see it in the innovative models like the capitation, and it is very good for us to be able to offer them these different formats of practice.
Thank you, Marguerite. I believe that today it's really important for all the professionals to be able to choose the model that is the best suited for them, because, well, we understand that we have some people who are professionals, and today I'm representing the liberal professionals because this is my profession. Can you, and I also am talking to all the different colleagues, and we have a lot of different healthcare professionals who really enjoy the system, paying by act or by intervention and things like that. And yesterday we have had this very beautiful conference talking about the sense, so what this sense actually means. And today I have one of my associates who also decided, who decided to change. They were just like, I cannot stand it anymore, so I will go into agriculture. I will no longer be doing this job of doctor because there is no sense for it. I don't know how to work with the patients and how I can continue doing the very good job and really, really satisfy all the healthcare need for the professionals. So they just decided to change completely. So I have some colleagues who are doing that, changing the sector, doing into agricultural things like that. Yeah, so she started working in agriculture. So right now she is basically working with chicken. So she will be growing chicken. No longer being a doctor. Maybe there is a multitude of systems, and I think that Marguerite has already said it. We have some things that don't work, and it's also very interesting to look at that. But I think that we have to look at the quality of life of the professionals. And at the same time, well, we can see it today in the studies that globally the professionals are working a little bit less with respect to what is the medical time. So right now, this is basically a final result, an outcome for the doctor or for a nurse. So what is this outcome? Well, this is to do the quality job and through the expertise that is required by all of our citizens for their treatment. And of course, at a certain point, we need to have an assessment. And I think that we have also talked a lot about the assessments, because today we understand that our system is basically no longer working, no longer doing what is needed. it, and we have looked at the constraints, and we have seen all the conventional side of it, and we need to understand all these constraints. And then the question for us is how and what will be the quality that we'll insert into it. And through this quality, we understand that we have different margins for action, and we have already offered it. With all the different goals, we understand that we could have done even better. Let's say, taking big important targets, let's say like diabetes or heart disease or heart strokes or things like that. We understand that we could do even better with respect to the patients, but we will have the envelope necessarily that will allow us at the same time probably to a little bit compensate for the deficit of the social security, but specifically and especially to reinvest in health and in the wages of all the healthcare professionals. And I believe that this is the most important thing, meaning that we also need to ask for the commitment of the healthcare professionals, because we are paying the same way that we did 20 years ago, but things have evolved. So you are basically happy with the way that the nomenclature is managed here in France? We are looking at it. You think that if we change things, if we change the capitation, we will change a lot here? Well, I think that we actually have to look at different margins for the maneuver, and we have to look at it from the financial side as well. I think that through quality, and you have already said it, through quality, and I think that at a certain point we will also be doing some savings, because we're talking about 20%, 30%, but can you measure the quality? Well, the quality against non-quality. Yes, we can measure it against the non-quality, the absence of quality. So I think that at a certain point we have the elements right now to do even better. So we have to use all of these elements. We have to take this commitment and to use all of this. Marguerite, can we imagine the payment of a healthcare professional, let's say, in function of their age, their training, the time that they have spent practicing and consulting? So do we have some criteria that we can probably define so that to pay a healthcare professional at their fair value? Well, we are basically paying for the treatment, for the care of a patient. This is what we have in the convention for the family practitioner, let's say. The consultation will be of 30 years, and then we have also introduced the capitation, which means that from the point where we have a general practitioner, the general practitioner will have a payment, and this payment depends on many different criteria, whether the patient is in a difficult financial situation, what is the age of the patient, and also where this patient is in their treatment. Probably this is the scanning of diabetes, of cardiovascular diseases, and so on and so forth. So the payment of for the patient is not really depending on the professional himself or herself, on the general practitioner or the family doctor. So if we have to better pay probably a general practitioner with a lot of experience and so on, well, we are basically placing ourselves on the patient's side. So this is the debate that we are having for 20 years right now, whether we have to have the capitation or the rates or something like that. Well, I believe that we have to have all of these elements, and the system today is doing all of this, and the convention, such as we have signed it, allows us to have a very good balance. First of all, the rates per act, which is also very important, because we have insufficient medical resources, because we need a certain productivity here. And on the other hand, we have this payment that is a fixed fee as well, that is adjusted depending on the patient and depending on whatever the doctor has to do for this particular patient. So the fact that they have to spend more time with this patient for the prevention and so on and so forth. So these two systems are already existing. And I also wanted to go back to what Patrick has said. I think here, and this is probably the most important topic here about the payment of the healthcare professionals, I agree, and generally I do not agree with him, but here I agree with him, And be careful, this is recorded. Okay, so the most important question today, the biggest question today, and I think that we have too many different debates with respect to what type of payment and so on. So the very first question is whether we have to better pay the healthcare professional. Yes, the answer is yes. In the normal organization, in the this division between the capital and work, we have 2/3 right now in France, and in the healthcare system, we are very far from this 2/3 that we have in general in France. So we look at this sharing of values and how the value is spread. How do we attribute the value to the healthcare professionals' work? So with respect to everything that is right here aside, meaning the drugs, the sick leave, and so on. So if you look at the sick leave, this is what Patrick was saying, and this is a very fashionable topic right now. So this is the envelope of 17 billion euros that is increasing of 8% this year. So 8% for 17 billion euros, it means that we will have 1.3 billion euro in addition. And I think that everyone who has negotiated in this room, all the healthcare professionals, you understand what it can represent. So at the end we say, yeah, this is nobody's fault. Yes, this is multifactorial, so it's very difficult to talk about it because there are demographical reasons, but also the wage increase, general wage increase, and so on. So we can all say, this is not my fault, this is the fault of the society, and so on. But we all have a certain part of responsibility in all of this. We are the social security. So if we have one person who is in the sick leave for 12 months, we have to call this person in to ask what is happening, whether there is a problem with their employer or whatever. Some of the prescriptions are typical prescriptions. We have to understand why this prescription is here. We also have some patients who stop working for very bad reasons, and we have the central actor that is not sufficiently controlled today, and these are the employers, because the employers have a very important rate of absenteeism today with very important differences. We have 25% in some parts of the market, more than in the other, in terms of the absenteeism rate, and the reality is that if the absenteeism is as that important, probably we have some maltreatment at work and the management that is not correct. So we would like to understand what we will do here, because we actually need to somehow put this responsibility on the employers as well. So yeah, of course, we have the drugs, and the cost of the drug is absolutely incredible. We also have a lot of different drugs that are much too expensive, but we have the equivalents that are less expensive that are not prescribed. We have biosimilar drugs that are practically not used, and we actually have to improve our situation here as well, because I think that we have to put we're putting less money in the prescriptions by the doctors, but more in the tools, probably in the equipment, I would say. So we basically have to look at where the value is and place the value in the right places, I think, because the value of the healthcare system are the healthcare professionals. So we have to basically place the value on them, place the capital on them. So I would like also to give the floor to Marie-Benque, who is via video with us. So hello, Marie-Benque, you are the general practitioner. Yes, indeed. And you are working in Ipsos Health. So please talk to us about Ipsos Health. What do they do? And what is also your the way of pay you are getting paid? Because this is our main topic for this morning. Yes, so Ipsos Health, this is Ipsos Santé, Ipsos Health. This is the network of the healthcare professionals. And yes, indeed, today I am with you because for 4 years we are fighting against the fixed fee system. So for all the general practitioners, just like me, we are fighting against it because, well, this is for the patients who are having the family doctors. We are having this fixed fee per month, and it varies with respect to the complexity of the patient, but also with respect to the medical criteria, social criteria, psychological criteria of the patient. So we are basically having this fixed fee per family doctor, and we are pushing this fixed fee as much as possible so that to have this capitation for the patient who have their family doctor, so per act. And then we will probably see in some other patients that are not our patients, like we're not their family doctor. So yeah, so this will be like emergency patients. Yes, indeed. So we will have some acts for these emergency situations and also some probably technical acts like, I don't know, sewing a wound or something like that. And you are all the doctors, the family doctors, general practitioners, right? Yes, indeed. And it's basically like the action that we are carrying out is called the strengthened family doctor, because we have some additional teams that are around us. We also have recruited some advanced practice nurses, and it's very difficult to find these advanced practice nurses that are helping us a lot for the treatment of people who are who cannot leave their home. And we also have some social coordination that has been recruited by our center, so that to help people that are socially vulnerable. And we also have this system that we have created, a system of partnership with psychologists that can work with different patients that need them and that have a lot of difficulties to pay a psychologist. And after 4 years of different experiments that we have had, we understand that it works well, and the patients are very happy, but the healthcare professionals are also very happy in this system, in this ecosystem that we were able to create. And for the experiment, this is actually very efficient. Are you earning more if through the system than if you were paid per act at 100%? Yes, indeed. The general practitioner is, in average, earning more than what they were earning per act through the consultations before. Well, we understand that Paris is probably one of the most important medical deserts in terms of the general practitioners, right? Yes, indeed. Well, then we have some different places and different conditions. Yes, indeed. Well, I am in Paris, and I have a lot of general practitioners who do not accept new patients anymore. So in your case, do you refuse a lot of patients? Do you not accept a lot of patients? Yes, indeed. We have some patients that are older, meaning that are all for a longer time with us, and we will focus on these patients. We also focus on people who are living right around us, or probably people who cannot really come and see us, who have to stay home. So we are pretty much limiting the geographical perimeter for all of our patients. But also, I wanted to add that I agree completely with everything that has been said before about the fact that it's very important to pay at their fair value all the healthcare professionals, and probably we have some savings that can be done on prescriptions and things like that. But we are actually waiting for the results of this experiment, for the assessment of the results. But I would like to say that when we're looking at the participant doctors, we have at least 30% less of the prescriptions through the centers such as ours. And when we look at what it represents, we understand that this is very interesting. But this is why we are carrying out this assessment, because we don't want to have any bias, and we are looking at the average payment of a general practitioner. So, Marguerite, the Social Security is basically following all of these experiments very closely. Yes, indeed. We will do this assessment at the end of the year, and after the final assessment, because you have had already one of the assessments, which was a very positive one, but you will have another one later on. Yeah, just before I will give you the floor, can you please explain us what is this Article 51? Article 51, I don't know if Frank is in the room, because if he is, he will be monitoring what I say. So the Article 51 is the possibility to get some additional financement when we are having an innovative model in a certain territory. Let's say we are in the territory and the Social Security can probably do some payment for acts and things like that, but then you will have an innovative structure, let's say in addictology or something like that. Well, a certain institution or establishment that will be doing things differently. And the goal of the Article 51 is to cover these projects. These projects are mostly financed at the territorial level. The IRS is financing it, but after 3 years, they have to stop their financement. So the advantage of the Article 51 is that we are immediately placing these kind of projects in the conditions where we will be assessing them, but also doing this financial accompaniment. So the Social Security will be looking at this evaluation, this assessment, and if this is positive, they will be looking at the possibilities to finance it. So what is very interesting with the Article 51 is that it actually shows us that we have some needs, some groups of needs, and what we need, what we see in in the Article 51 is that we have many different factors in the payment of the healthcare professionals, but also for the healthcare professionals that are not being paid by the Social Security but for their acts. So when we're looking at the physical activity, adapted physical activity that you're adding, or probably motorical activity, you're always using this Article 51 so that to create your center that will be a little bit innovative. And this financement can last for a certain time. Yes, indeed. If the assessments are positive, the financement will last. But what is also very interesting here is that when we have approximately 30 different experiments, let's say on the autism, because we did not cover enough the psychotherapeutes or, I don't know, some additional specialists or things like that, the common things. So the question for us will be, if this project works well, whether we will be also probably integrating it into the common model. So for us, for the public authorities, that's the question of looking at this project later on and probably integrating it into the general legislation, because probably this will be the need for this territory, and this will be something that is long-lasting. Can you please talk to us about this innovating rates? Yes. Well, Marguerite has just explained the framework of the Article 51. Yes, indeed, this allows to us, to the professionals who are on the field, to innovate the organizational models, but also to offer the economic modalities that will be innovative as well. So we have created an association, and the goal of this association is to rethink, and this is also the theme by CHAM this year, rethink the healthcare by the humans. And we are inspired by the model coming from the Netherlands, and they have this model that is called Buurzorg. Probably some of you know it. So right now we have 4 years of experiment behind us because we started in 2019, and this is the innovation for the healthcare in the city. So we are basically working with liberal professionals, and we were able to experiment for 4 years in 4 different regions in France: Hauts-de-France, Île-de-France, and Occitanie. And right now we have approximately 250 nurses, liberal nurses, who were able to test this model, approximately 25,000 patients who were part of this experiment, and many different appointments during this time of innovation. So today, just as Marguerite has said, this is Article 51, so a very, very precise framework, and the assessments. So what you were saying before that is fundamental, because our colleagues from Holland are basically a pillar for us, because their system is being assessed all the time, self-assessed as well. And this is something that I have seen in the field, that we are actually in lack of assessments. Well, this is not the crucial topic for us today, but I just wanted to mention it. And I'm actually thinking about this creation of the observatory of the treatment at home that does not exist today at all. So what is your concrete offer for the payment? Well, the experiment and the innovation has 3 pillars. First of all, the nurses are taking care of themselves globally with the centered on the patient approach, aiming at the autonomy as much as possible. Concretely, they will come to the patient and they will be looking immediately with the helping practitioner what the patient can do, and they will try to formalize and to make the patient talk about their true need in terms of healthcare. So this is a little bit like a holistic approach, I would say. So they are aiming at the autonomy of the patient. The second pillar is to maintain all of this, and the third pillar is to allow the nurses to work in teams, and this is also very innovative in terms of the organization. This is also inspired by the Netherlands model, because we are basically doing the follow-up for the nurses, and they are working in teams that are self-organized. And I actually see very well that this is not something that is just coming from nowhere. And I actually had this experience about this topic for the pedagogical framework with the student nurses, who today are stopping their training, and even with diplomas they will never work as nurses, just because finally they cannot see the correspondences and the matching points between what they learn at school and what they see in the field. So this is actually an additional hope for the nurses, because when we allow them to work in teams, I believe that the lever of the support that we have selected for these 3 pillars is to allow the nurses to invoice their treatment based on the hourly rate, which is basically which is basically invoiced per minute. It means that all the nurses can basically work with all of their skills and being recognized for their work, and all the nurses are very happy with that. So if we have happy nurses, trusted nurses that can work and use all of their skills, so this is very, very important. This is related to one of the topics of CHAM this year, because the very first cause of the loss of sense of the nurses is that they're not using all of their skills. And, well, for us, the nurses are very happy and very fulfilled in their work. And I can say that, I see people who wanted to quit some time ago and who right now with the system are super happy and want to continue working. I think that that's a great idea. Jean, what do you think? This is a good idea? Yes, this is an excellent idea, just as excellent as the other one that we have talked about before. So I think that things are moving forward, but we actually have to also look at the social security and to make sure that they will be managing everything without having deficit, and the doctors will be happy and the surgeons will be happy as well, because I think that the surgeon with a lot of different skills and competencies that are very, very niche competencies, specific competencies, would not be paid as the lab worker, let's say. So I think that the differences must be clearly visible here as well. So you see, I think that we have to be. Well, we stop joking. We cannot really compare things that are uncomparable. Yeah. It's been 20 years since we started talking about this, and today I think that we actually have to go back to the field, and the biggest revolution is not something that is expected for tomorrow. At least that's not what I have heard yesterday and yesterday evening. So we are trying to be very pragmatic and to look at how we can move forward. I have this principle for me. I think that today the patients are asking for what? They need expertise. They need efficiency through the relevance, and we actually have to grant them that. And they also need an assessment. And I have always asked to have the assessment for everyone who are part of the convention. And tomorrow we will be promoting all of this. So if there are things that don't work, we have to erase them. We have to stop them. But this is not the principle in France. But also this phenomenon of commitment for all of the professionals. Today, we have had this very important revolution. We are living longer. The chronic diseases are here. The cancer is here. And when I have started before, we had a cancer, and 1 year and a half later, you were no longer of this world. But right now, we have the follow-up that is present. So we have the responsibility that is through this society. We also have this responsibility, which is territorial responsibility, and I think that we have to go further with this. But we also have this principle of reality. The principle of reality means that if I am paid per act, well, I am producing. And I am responding. Why? Because I believe that in France we have this problem of access to the healthcare. So I would like to ask to all of these experiences of Article 51 that I am very much in favor of. I believe that this is fantastic. This is great because it actually allows us to move forward. But are we providing a better response in terms of the access to the healthcare? Yes. Well, let's wait for the assessment, I would say, because I would like to see whether in some of the structures or establishments we see more patients. So that's the question that I'm asking. Because what I see today is that the population is saying we have problems in terms of access to the healthcare. So I'm trying to bring an answer to this, to find an answer, because we have some structural problems. Yes, of course, we have some structural problems, but these structural problems should be tackled in a non-structural way? No. It's to probably tackle them in a linear way and to convince the field, because I believe that the hardest part here is exactly this break, this hurdle that is on the field. I would like to go back to it in terms of the access. The access to the healthcare is different for the patients, yes, indeed, because in the nomenclature for the nurses, we don't really have this contact. And we have some that are having a surgery or not, and we have basically the the hourly rate, and all the patients are having the same value. So it actually gives the access to the healthcare as well. And I will not really be talking about the satisfaction of the clients that we see, satisfaction of the patients, but also the savings, because we have actually 9 million euros of savings for the social security through our project. So when we're looking at the assessment, this is also the continuous medical training, right? Yes, indeed, but these are also the assessments on the very innovative models. And just to reassure you, beyond all these innovations that are part of the Article 51, we have also signed the convention for the doctors who are like very willing and want this capitation entirely, they can do it. So from the pragmatic way, we're basically looking at what Patrick is saying. We have many different ways of exercise that are possible right now. And I think that for all the healthcare professionals, well, they don't have the same these same goals, all of them, so they need to find a work, a certain form of work that is the most fulfilling for them. Either they would like to spend more time with a certain patient or less time with a certain patient. Probably some acts will be a little bit more difficult physically or technically than others. So we actually need to have different possibilities for everyone. And for us, it's important to have the maximum of value in terms of the payment for the healthcare professionals, which is why, indeed, we need to have the relevance here. And just to finish on it, I believe that at the end, the biggest structural reform, because we can have to talk about rate and things like that, but we will not change the life of the patient. For the patient, we need to offer them the general practitioner or the family doctor that will allow them to have the healthcare, the primary healthcare that is the most important, and to have the prevention as well. And the prevention has a lot of factors like food and diets and things like that. But we, as healthcare stakeholders, we have a lot of things to do in terms of the scanning for the chronic diseases and things like that. Because when the person gets to the hospital, that's too late. The cancer is not good, and this is the goal that we have for the upcoming years. Yes, indeed, and also pay a lot of attention to the disabilities, the precarity, and the vulnerability. Yes, indeed, because mental health and disabilities and things like that are also very important. Well, the mental health probably for the society, and for probably the conclusion, imagining Guy Valenciennes next year through video conference with us as a Minister of Health. Yeah, and I would like to mention something that is very clear, is that we are offering the alternative to what is existing. We are not imposing a model, and the nurses will be able to choose for themselves. Thank you very much. Thank you to all of you.